I'm just going to go ahead and record this. Okay, so again, March being Endometriosis Awareness Month, I thought it would be great to do this interview with you. So just some of the questions that I think just even starting our article and starting this interview would be, what is endometriosis, and kind of what are some of the factors or things that we think contribute to it? Because I know that there's a lot of thought process now, a little bit of a change and shift of paradigm and narrative on what we thought endometriosis was. And it's interesting because I look at some of the well-referenced sources out there, like the Mayo Clinic. What else do I look at? The Cleveland Clinic. And I feel like there's still kind of a little bit in that old thought process of what actually endometriosis is. So if you can just tell me.
So the way I usually describe endo to my patients when I'm like just starting the conversation, someone comes in and is telling me about their pretty painful periods, and we'll talk about kind of the symptoms that are most commonly associated with it, but like painful periods that are beyond sort of the norm of what pain should be for a period. And this could be at any point. It could be teenagers, or it could be an older woman who's sort of referencing, oh yeah, my periods were terrible when I was a kid, or they've gotten bad again, even though I've been on a medication or whatever it was. When they're talking about that, the way I bring it up is endometriosis is a condition where cells that are similar to the cells that are in the lining of the uterus are actually found outside of the uterus in places they don't belong. So it could be on the surfaces of the uterus, along the side walls, on what I call is like the wallpaper of the inside of the pelvis. So that's like the peritoneum. It lines everything. So it kind of then finds its way into that layer. It can be in the ovary and cause a cyst. And that's what we typically reference as a chocolate cyst for an endometrioma. It can be on the surfaces of the bowel, the bladder, and it can cause locally, these cells respond to the same hormones that our uterus responds to when our period comes, and when we ovulate. So those cells respond in similar ways, where they will sort of inflame and get sort of active based on that, hormonal stimulation. And locally, because there's nowhere for those cells to bleed out the way that our, uterine lining will shed out, locally, it causes a lot of inflammation and can cause adhesions and scarring. And that's really where those two kind of factors of endometriosis is, I think, where a lot of the symptoms come from. It's, one, inflammation, and two is the adhesions and scarring, which distorts normal anatomy. So things like the bowel and the bladder can become adherent and stuck to layers it's not supposed to be. The ovaries can get pulled in. These surrounding ligaments can tighten. And that can start affecting the muscles and nerves. So, that's why it becomes, it can be a very challenging disease, because we have terminology that says like stages of the disease. So, we have different stages where it's like either superficial or it can be very deep. And we say there's even deep infiltrating. So that's the whole spectrum, but patients' symptoms can be different. It doesn't necessarily correlate with the degree of disease, which is not usual, right? Most diseases, the more disease you have, the more symptoms you have. But with endo, it can be, because there's this inflammation factor as well. We're not really sure why, but some people can have very superficial disease, but very severe symptoms, and other women can have very dense fibrotic disease, very scarred tissues, and have very minimal symptoms. So it's very varied in the way people present. The thing about endo is I don't think there's enough education on it. It often takes a woman or a patient seeing multiple providers before they actually get to the conclusion of endometriosis. It could be multiple specialties. I think one of the statistics is anywhere from like 3 to 5 specialists before they actually get diagnosed. Often it's an 8-year journey from the start of their symptoms when they start seeking answers before they finally get the word endometriosis even said to them, as a consideration, which to me is crazy, because it's like 10% of the population has endometriosis. So it's, it's something that should come to our foremind more frequently. you asked about like, what are the theories? Why does this happen? So there was that sort of old school theory, which was what's called based on retrograde menstruation, where that the cells that were sort of in the uterus made their way out of the fallopian tubes and then found their ways to implant. Now, if that was the case, every person with a uterus would then have endometriosis, right? Because we all have retrograde menstruation. We have an opening through our tubes, and if our tubes are open, then cells will spill out. Not all of them implant, and there could be, maybe there's some patients who are more prone to implantation versus other, but it's definitely more complicated than that. They also believe that those cells aren't actually exactly the same as the endometrial lining cells. They think they're very similar. There's a genetic component because we know it can run in families, so there's got to be genes that are involved. I've found that there's many different other sort of conditions that can go hand in hand that patients might have at this, at the same time. So again, that sort of lends itself to sort of this idea of genetics. And we really think, I think, one of the most viable theories, and where they have really good data on this too, that's been developed, studying different models, even mice models. They looked at, these cells, and they've actually found that one of the ideas is that they actually implant at the time that we're developing as like embryos. And so these are cells that are, kind of implanted in those areas way before, and then they start waking up as our hormones turn on in menarche when we first get our periods. And then again, the progression is different. Some, will have symptoms right away, like from their very first period, they'll have terrible, terrible symptoms, and others, it'll be sort of a slow progression that it gets worse over time. So there's a lot of factors, I think, that we still don't know, but I think it's really important to kind of understand the disease as being very sort of complex. It's not as simple as something like retrograde menstruation. There's a lot of other factors involved.
Right. And you've answered a whole bunch of the questions that I had just from that basic information about, and again, it's still being, that kind of old school theory propagated a little bit with the retrograde menstruation.
Yeah.
And I think they say 9 out of 10 women have retrograde menstruation. So as you said, if that was the case, everyone would be walking around with endometriosis.
Right.
And it is incredibly interesting with the whole cellular genetic link with it.
Yes.
The fact is that they are doing, again, the studies with the embryos. So, we are born essentially with these cells, just like I suppose we're born with like proto-oncogenes too.
Correct.
And it's like, are there factors from even an inflammatory standpoint, from an environmental standpoint,
Correct.
that these cells are being turned on essentially?
I think that's a really interesting way to look at it. And I think that's probably where, why we need more resources put into the study of this disease.
Yes.
Because I think there's going to be some really interesting information about exactly that. What turns it on, what makes one woman more likely to have more aggressive disease versus another, at what point it becomes symptomatic, like all these different parts of it are so complex. And I think really, so, to my patient who's been suffering, right? You don't necessarily care where it came from, but
Right.
I think the really important link for them to understand, because when they start understanding it as an inflammatory disease,
right,
so many things connect for them. You know what I mean? Like their bowel habits, their urinary habits, why their pain is a certain way, why they're fatigued, like all of these things start to make sense. I can see it, like they're like, oh, like that explains so much, So I don't know. I think that part of it is really what I find so eye-opening.
Right. And I think then that could help that empower them with guiding their treatment and management of it.
Yes.
Because again, we have so many ways now that we think about inflammation within our body. So environmental triggers that are contributing to that, food and things that we put in our body and on our body that could cause that. And then again, a little bit too is the, this thought as a contributing factor is this whole idea of excessive estrogen in our body. And, is that really, potentially something? Again, I think this is, as, we start to understand more and learn more, we'll be able to have more solid information and evidence on that. But just this idea of, is excessive estrogen causing maybe these cells to kind of turn on and become overinflamed? So then how could we do, as far as when we think about more of a holistic treatment?
Right.
So we can kind of talk a little bit about that, but I want to, before I even go into treatment too much on that, is again, ways that, do we think about maybe, controlling estrogen? And that, again, that might be a treatment, that might be even how we look at inflammation, the food that we put in our mouth, our body, and things like that would be interesting. But, you had said it before, interesting, that it is about 1 in 10, right, is kind of that statistic, or about 15% of women worldwide, right, menstruating women worldwide that are experiencing endometriosis, and that it takes so long, unfortunately, to be officially diagnosed. And they said the average is about, again, 5 to 8 years, right? Or I think the study was something 3 to 10 years. So that average is about 5 years for someone to really be diagnosed with it. So what are some of the ways officially for someone to get that diagnosis of endometriosis?
So this is where I think people have such a hard time, physicians have such a hard time saying diagnosis. And it's because we're all traditionally trained that the gold standard for diagnosis is surgery. So seeing the disease, getting a pathologic diagnosis, a sample of the tissue that the pathologist confirms endometrial glands that aren't supposed to be anywhere else except for inside the uterus, when you find them outside. That is how you officially, gold standard, diagnose it. That doesn't mean I've taken all my patients to the operating room to confirm they have endometriosis, right? So there's the other side of it where I say you can make a clinical diagnosis pretty quickly. With some very key questions. And this is where I usually, can, in my discussion with a patient about their symptoms, kind of narrow it down, or at least float the idea. And I think that's really important, because many young patients will get started on a birth control pill for painful periods with no discussion as to why they might have painful periods. And I'll say, okay, maybe not the wrong thing to do, because it'll help their painful periods. But if you don't have the discussion, if you don't float the idea, they'll never have that idea in the back of their heads when something starts to change about their bodies as they get older, and to ask the questions and to bring it up and to say, you know what, my periods were painful back then. You know what I mean? So often a patient will come and I'll ask, are your periods painful? Well, when you're on birth control, like, were you put on that just for contraception, or were you started for a reason? Oh yeah, I had horrendous periods when I was a kid. And that's when I started when I was 16. And okay, now we start diving into that a little bit, right? Like, so having that conversation, floating the idea. So when I have a young patient who comes in and says, my periods are pretty terrible, I'm not going to say we have to go to the operating room to confirm you have endometriosis. I'm going to say, there's a chance you might have endometriosis. You should have that on the back burner. I think we can treat this. We can manage it hormonally. If it works, great. We'll keep an eye on it. We'll do the things that we need to do, but let's talk about it. It's an inflammatory condition. This is how your life could be affected. This is how, you know what I mean? Because many women come to that conclusion way too late. And then by that point, it's affected their bodies, their diets, their relationships, their fertility. Like, I mean, so many aspects of their life before they have an idea of what's going on. So I think that diagnosis piece is really critical. And again, it could be a clinical diagnosis. Are your periods painful? And what do you mean by painful? Okay, like, did you ever miss school or work because your periods were so bad? Any nausea or vomiting? I had a attending once that said the bathroom sign. If a patient would say, oh yeah, I'd be like curled up on the floor of the bathroom once a month because my periods were so painful. Just laying on the cold tile was the only thing that helped me. Like, that's not a normal period, right? Like,
right. And I think we don't, and I think you're right in the sense that it takes far too long to get to that point to kind of say to people, and I hate using the word normal, but it's not, optimally supposed to happen.
It's not in the scope of what we consider
Yeah.
Acceptable.
And yeah.
Painful
And I
cramps
think,
managed by over-the-counter medications. Okay. But beyond that, no.
right. And I think that so many things in the world of women's health, in the world of pelvic health, that we just accept these things as like, oh,
well,
it's
there's
just
a lot
supposed
to it, right?
happen
There's
in
the
normal.
stigma. We're not supposed to talk about it.
Right.
No one's supposed to, it's a secret. When we have our periods, it's a secret. No one's supposed to know. We're supposed to stay stoic. We're not supposed to share our discomfort or pain. And then remember, there's that genetic component. So some girls will bring it up to their the women in their life, their moms or whoever. They're like, oh, that's just how your periods are. My periods were like that too.
Exactly.
But nobody realizes there's an association.
Right.
So they get like almost like well, I guess it's just how it is. And then no one's asking for help either. So it's like a very like crazy, like, sort of paradigm we've created around menstruation that allows this, So that period question about painful periods, nausea and vomiting, and then I'll ask things about, do you have any, changes or issues with bowel movements? Do you ever have any pain or frequency with urination? Do you wake up a lot at night to pee? Stuff like that. Pain with sex. Is intercourse painful? So things of that spectrum, those series of questions can give you a sense of, okay, should I be having this in my differential? Should I be thinking about this as a possibility?
Right.
And
a step down from, or a large step down from getting, clinically being diagnosed by an actual laparoscopy or surgery. So the exploratory surgery. What are your thoughts on ultrasound? Because I know we've talked about this
so
quickly about what can we find out with some more traditional standard,
so
like
here's another
an
thing.
ultrasound.
Again, the things that feed the myths, right? There's so many myths surrounding endometriosis. One is that, oh, you can't have it if you're young. Teenagers don't have endometriosis. That's not true. Imaging. Oh, your ultrasound is normal. You can't have endometriosis. That's bullshit. If I had to guess, I'd say 90% of my patients have normal ultrasounds, and they may have anywhere from stage 1 to 4 disease. Ultrasound is a great tool for certain things. I do think it should be part of the investigation, because if someone has an obvious endometriosis lesion, like an endometrioma type cyst on the ovary, that could be basically confirmatory on imaging. But ultrasound, there's an art to ultrasound that I don't think we've fully grasped universally. There's some great studies. Mauricio Brau has done some amazing studies in Brazil, training technicians how to do what I would call like dynamic ultrasound, doing an ultrasound while doing the exam to see how the organs sit in relation to each other, right? Because the uterus and the ovaries and the rectum and the colon and the bladder should be somewhat independent of each other. They're all next to each other, but they're not fixed to each other. Right. So doing it, these ultrasounds, when a tech or a physician is properly trained to do them, it could be helpful. They could see, well, your ovary seems plastered to the back of your uterus. Well, that's not supposed to be there. And that's a great sign. That's an endometriosis sign that you can see laparoscopically, that if you can, you can figure out that orientation, the imaging could take you a lot further. It's just unfortunately, that art isn't as fine-tuned. So we can't count on it. So that's why I can't say, and I'd hate, to hear when patients say, oh, well, I had a normal ultrasound when they looked and they said I didn't have endometriosis. Right. I was like, well, that's not how you diagnose endometriosis. So, so that's often, again, a myth that gets propagated and then sends people down the wrong path because, they've been told they just can't possibly have it. MRI is another potentially helpful tool, but same thing. It doesn't always show those layers as clearly, to be able to really tell. So,
And when you look at things like the ultrasound and an MRI, we're not necessarily seeing like those, those lesions, essentially. We're seeing more of the ramifications of, the essentially the adhering process a little bit and how it affects. So it has to be really dynamic and in order for something like that. And I think that's the huge limitations with the world of radiology and the world of ultrasounds, is that we can't always see adhesions happening, and we don't know, but we know that that can play a huge component to the motility and the function of those organs, pain, and all of those quite interesting things that as manual therapists. So as physical therapists, manually you get in and we're like, we're starting to, really dive into this world of visceral work, this really world of myofascial work, and being able to move the soft tissue and move the organs to better improve maybe their function possibly, but to improve basically their orientation on the somatic framework, really is what it comes down to. So that's some of the limitations with that, but I can understand with my experience of just using ultrasounds in a real time, looking at muscles, looking at how things work, that you definitely have, it's a skill,
info, right?
Yeah, but you get a lot of info.
You get a lot of information. The other part of it is a really good physical exam. So, doing a pelvic exam, a rectovaginal exam, again, many patients have come to me, they've never had a rectovaginal exam before. They're like, eyes pop up and they're like, you're going to do what? But I tell them, it's like endometriosis lives behind the uterus. It's like if I do a rectovaginal exam, I can examine that plane. I can feel your uterosacral ligaments. Are they tight? Are they tender? Is there fibrosis? Does it feel hard? That tells me a lot of information. Does it feel like your ovary stuck down here? It's not, it's supposed to be up here, but if it's down here and it's tender when I touch it, that's concerning to me, right? Like that raises my suspicion. The examination of the pelvic floor. I can't tell you, I've told you this many times about how many times, OBGYNs don't get trained on pelvic floor examinations. So being able to tell someone, you have pelvic floor dysfunction, your hypertonic muscles. This is why you're having pain with intercourse. Like these are sort of, to me, it's not because you have endometriosis in your pelvic floor muscles. It's because that's a secondary change that has been happening because you've had pain for so long, right? So here you are. These are all confirmatory things to me. This is all part of the big picture. But again, you're now giving them more information about why these things are happening. Why are they feeling? Why does it hurt when they, sit in the car for their hour-long drive to work? And by the time they feel debilitated by the time they get out of the car because they're sitting in that, posture, they're stressed in traffic, and like, what's happening to them, right? Like, why is their bowel function and their bladder function, off, like, and dysfunctional and painful. And it's just, there's so many aspects of it, right? Like that on an exam, you can evaluate that. But again, there's an art to it and a skill to it that, like, unfortunately, we're not doing justice to both sides. I don't think we're doing enough in training, to our young physicians coming out. And I don't think we're giving patients enough information, from our evaluation anymore. So like, it frustrates me.
I can understand that and see that because, we then just end up, again, our patients not being well informed, and they don't understand how they can play an active part as well in helping themselves. Number two, we're just giving them a pill or medication as a Band-Aid and not really kind of understanding those underlying factors and bringing then that holistic approach to treating and helping patients really is what starts to happen. And then there's that immediate breakdown once we just say, we'll just take the pill and that's it. And people are like, okay, well, again, they don't know. They're not real well educated. And it is up to us, I think, as the providers and to really be able to kind of push that change a little bit with it, which is awesome. And so that kind of brings me a little bit into, again, it takes a team approach to treat, right? It takes a village to help these patients, and from the standpoint of what you can do from the medical physician aspect, what we can do from the physical therapy aspect, pelvic physical therapy in particular, especially when we have muscles and posturing and breathing in a way that our nervous system has adapted because of the long-term changes with pain. And we know sometimes from just 1 or 2 episodes of a pain experience, our body and our nervous system can change tremendously, right? And so being able to kind of pull that in as treatment is so, I think, important with, with how we help not only people with endometriosis, but just chronic pelvic pain or, you know, these inflammatory types of other conditions or chronic conditions like interstitial cystitis and painful bladder, you know, all these other conditions. Absolutely. So, you know, from your standpoint, you know, I know you, so I know you refer for physical therapy, for pelvic physical therapy for people that we are certainly questioning. And when you do your pelvic exam to know, hey, obviously their pelvic floor is responding a certain way and we need to improve that, right?
Yeah.
What other treatment options? And then we'll also talk about surgical too, because I just want to ask that.
So I usually, I'll usually say that there's like 4 sort of main things that I say need to come into the treatment. So if, you know, from the holistic side of things, I think diet is huge. So I often counsel my patients low inflammation diet. I often will reference low FODMAP, but it doesn't have to be low FODMAP. It's just, I think that's a good guideline and a good place to start. And it's difficult. And I explain to them, you know, it's very difficult. It starts with really cutting out all of these inflammatory things that, and then I usually would say in order to be sustainable, try reintroducing some things slowly and with kind of thought so that you can kind of figure out what certain triggers are for you specifically. But I've had patients really change things around with just diet and not have to do, you know, medication or surgery or anything. It's pretty amazing what a tool that is. So, you know, again, once you start understanding that inflammation component and you start altering your diet to correct that, it becomes self-affirming because a patient will say, I felt so much better. And then they have, you know, they start to slack or they have a cheat day or they have a wedding or something and they feel it almost immediately. And so it becomes affirming that they're like, oh, like I understand now, you know, so that's a big one. Pelvic floor physical therapy is a huge one. So for me, again, exactly what you said, you know, the breathing, the postures, the just what your neutral state is completely changes when you've been in pain for so long. So things that shouldn't be painful now become painful. Your nerves are responding differently. There's a sensitization that takes place. So there's, again, different ways that can be approached. But to me, the physical manipulation of it can really help. And then that too is, again, giving patients ownership of things that they can do when they're dealing with stress or they know they're going to be sitting on a long flight or, you know what I mean? How can they modify their behaviors in order to make this not so terrible, right? Like how can they self-correct because they've learned these tools. So to me, I think that's a huge piece of it. And then there's medications. And the medications come, there's a couple of different avenues for the meds. One is, you know, the hormonal side of it. Medications like birth control pills, or we have some like GnRH antagonists, and those are basically focused on regulating the estrogen stimulation. Like how do we either balance out, even it out, so it's not so volatile with the cycles every month, or down-regulated, down-turn them so that they're not, again, overstimulating those cells that don't need to be stimulated. So that's the estrogen type, estrogen management meds. And then there's, you know, from the nerve side, sometimes I have patients on like centrally acting medications to help with that nerve sensitization that happens. And this is the particularly like chronic pain, like they've been on pain for so long. We're really trying to avoid being on like long-term narcotics or other medications that could become dependent. So using some of these can be a tool, not meant to be forever, but a tool to help make progress, turn things down, reset that neutral for them, and then hopefully come off. And then some of the compounded type things that I use, like muscle relaxation, the diazepams or the topicals for the vulvodynia, you know, to kind of, again, you're helping with the local
tissue
upregulation of the nerve response, basically. So yeah, so for those local kind of treatments, I think that's the main thing from the medication standpoint, really coming at it from all those different angles. And then finally, it's the surgery. But I hesitate to say finally, because I always make a point to my patients to say surgery can fit in at any point in their journey. And that's really important, because I think some people need the validation, or they do on exam have factors that say maybe surgery would really help them. And what's the goal of surgery? It's not just diagnosis. It's not just take a peek, look around, okay, yes or no. And I think that can often be very misleading, because I've had many times where my first glance looks pretty normal, but then when I come in and I take a closer look, I'll see some minor, sort of faint signs of inflammations. So I always take biopsies, always take sampling of tissue. And my goal is excision on the endometriosis, because there's theories behind ablation, which is the burning of lesions, and excision, which is the removal of lesions, excising, cutting them out. And most of the studies have shown that excision leads to a better outcome from a pain-free interval. And not only that, that you're less likely to miss deeper lesions by just addressing the surface. Now, there may be some superficial that ablation would be sufficient, but the thing is, you're potentially missing out on deeper lesions by treating it that way. So that's why, I sort of really, I'm in the excision camp. It's how I was trained. I really believe in it. So, and that's a whole umbrella of discussing, what that surgery would entail, if we need other specialties, like how in depth are we going? What are certain organs, potentially needing to be removed, or are we just focusing on the lesions? Restoring anatomy, I think, is a big part of it for me too, because again, when you get things back freed up and in their normal orientation, it allows things to move more freely. And again, these relationships and that neutral state can be better established. But it's not one of those things that, surgery is for when you've exhausted everything necessarily. It can be part of that journey, because many times I'll say, fine, we do the surgery, but we still have to do all of those other things. You're not in the clear. It's not a cure. There's no cure. And I think that's another point to drive home, is that, this is a chronic condition. It's something that patients struggle with until they reach menopause. And even that, I'll say, if you have pelvic dysfunction or nerve upregulation and things of that nature, you may still need to work on things even after menopause and the hormones have shut down, because that becomes a physical, change that has to be undone, right? So that's another kind of again, myth that I think gets propagated, is that, oh, this all ends at menopause. It's like, well, it's still a little more complicated than that, because some of the things that change aren't necessarily just going to turn off in menopause. It's going to potentially start affecting you in other ways. So you may still need to work on it from that side. So it's really interesting, right? I think that it relates to the other organs and health. So many things that there's so much to talk about it. It's hard to do in a 30-minute appointment.
I know.
But I try to lay the groundwork of this is how we're going to approach it. We're going to throw the kitchen sink at it and really try to get it under control, because the goal for me is management and quality of life. That's what it is, right? You want to be able to do the things you want to do, and it shouldn't be holding you back.
Yeah. We said, that's so wonderful. So much information.
I know, right?
That you've given me, and again, and I think for many people, it can be very overwhelming. It can be very daunting. It can be very, very, very scary. It can have a whole slew of all these negative emotions with it. Again, it's, as we talk about, it's a chronic condition. The goal is management and quality of life, but we might not make it go away, right? There might not be an official cure for it. And so that can be very, very, very scary for people, right? And that emotion, whatever word I can't think of, is the really best word to describe that. But I think part of, helping people along this journey and along this is to let them know that, we are here to help. We are here to guide them. There are a number of treatment options that are available. There are a number of ways that we can help them improve that quality of life.
Right.
help people live a life that is many ways for many people could be pain-free. It
Right.
could be many ways symptom-free, right? And I think the more providers that we have that understand that are educated with that are not just kind of, falling back onto those old school thought processes, and we just give them the pill and we settle with that. I think the more that we can understand that, I think it will help people tremendously. So to take something that can be very scary and negative, to maybe, kind of spin it positively in the sense of helping to really support them, and give them so many treatment options. And that's why I think it's so wonderful that we have you here in this area, with us to be able to kind of be that person too, to understand and maybe change the narrative around working with people and helping people and treating people that have endometriosis or other types of inflammatory pelvic health, bladder health, bowel health type issues too, that relate to pelvic floor function and relate to women's pelvic health, really. So I thank you tremendously for sitting down with me.
Thank you too.
Doing this.
Yeah, no,
this was so good that maybe I should just record this and let people see.
I was going to say, I was like actually thinking about it at the beginning. I was like, maybe we should just do an IG live. Or and just do a little conversation. But yeah, I mean, you can use any of that. I'm happy for you too.
Yeah, we could definitely do that, or just, put this up and keep it recorded. Cause I think it's probably better than what I'm going to write, because I'm not a great writer, but you know what I mean? So you beautifully did it justice. And thank you so much for doing
You're welcome.
this.
Anytime, I love doing this stuff. So anytime you want to do something, I'm always game.
Yeah. And I would love to do, just going back on IG type stuff, we could totally do. So we have our Activcore Princeton _pelvic, which is where we're trying to really add in a lot more of the pelvic health content. And do all that stuff. So I would love to maybe sit down with you and have some of these conversations. And again, March is Endometriosis Awareness Month. So we'll hopefully get this kind of up on our site so people can start, seeing this, understanding this, kind of diving into it a little bit more, so that they can help empower themselves to seek out providers and treatment, and not just kind of settle for, hey, it's the norm. It is what it is, deal with the birth control pill and it is what it is. We don't want that. So, so good. Thank you.
You're welcome.
I'm going to just hit the stop record.